Dr. Michael Siah is here. He is a vascular surgeon at UT Southwest in Dallas, Texas. He's incredible. He's had several miracles with patients that have come his way from our organization and within our organization, some patients who have found him on their own. And so we're going to hear from him. We're going to talk about all of the different advances that are really catching his eye right now, maybe some of the frustrations he has, things that, still some roads we still have to pave yet in the care for peripheral artery disease, it's those blocked arteries and mainly the legs. 3 in 5 people who suffer a heart attack have these blocked arteries in their legs. 1 in 10, I think it is, over the age of 50 has peripheral artery disease, 1 in 5 over age 60, and diabetics, 1 in 3 over age 50 has peripheral artery disease. So definitely worth hearing what the advances are in the treatments. So here at this event, you've been on podium. What was your topic that you discussed, and what were the takeaways that you hope that doctors are bringing back to help their patients with P.A.D.?
So I had the opportunity to talk about practical applications of a clinical trial that was conducted not too long ago called the Best CLI trial, and how it's affected my practice. And the reason why it's important is it was the highest level of evidence that we can create as physicians. So we randomized patients to either open surgery or an endovascular intervention. And this was all for patients who had wounds, had non-healing wounds or pain at rest. And what that trial found is there's certain patients that benefit more from bypass with using their own saphenous vein. And then if you don't have saphenous vein, the options available to you all work very well. But ultimately, like you alluded to, peripheral arterial disease, when people have wounds, it's a very challenging situation, not only for patients, but for physicians too, because it's a predictor of badness, whether that badness is amputation or cardiovascular related death.
Right. And when you have these patients that we're talking about with the Best CLI trial, we're talking about patients with the most advanced stage of P.A.D. It's critical limb ischemia, or CLI, or CLTI, critical limb threatening ischemia, depending on who is describing it, but it's all pretty much the same thing. But in this Best CLI trial, they, as you said, they were comparing endo versus the bypass. But in either case, it's literally not it's not a durable solution. These procedures, they're just trying to see which method is going to be the most practical to get you the most blood flow to get those wounds healed if you do have those wounds on your foot. And that's typically right when we're talking about treating these CLA patients, is to heal the wounds. But it's to heal the wounds to get you back on your feet, to walking, to grow your collateral vessels. So you're not expecting either of the procedures, whether it's bypass or whether it's endo, to be a durable solution. You're just trying to heal the wound to get a patient back on their feet. And I think it's important for them to understand, right?
I mean, absolutely. I think there's a big difference between open surgery and endovascular therapies, right? And endovascular therapy allows a patient to be taken care of expeditiously and sleep in their own bed that night. You get to go home. If you get a bypass, it means you're getting a big incision. It means you're going to spend some days in the hospital, and we have to worry about the surgical wounds we create healing too. That being said, the expectation, the data we have is, if you do a bypass with vein, it's probably going to stay open for a little longer than a stent in your SFA or a stent in your thigh. But not every patient can get that type of bypass. And, anecdotally, based on my experience, not a lot of patients that I see in my practice day to day have veins that can be used. Yeah. In those situations, we rely really heavily on endovascular solutions. And then in some situations, we think about using alternative conduits like PTFE or a graft, or in even worse situations, we have to think about using cadaveric tissues, somebody else's vein, and using that to do a bypass, which in and of itself has its own shortcomings.